Hi guys, and welcome back to part 2 of chapter 40. We're going to get back into it. Now, part 2 of chapter 40, we're going to talk about technology. There's patients who use technology in their everyday lives to help make maybe either different medical issues or problems, or even just illnesses easier. Some of this technology is actually life sustaining, and some of it just makes your life a little bit better having some of this technology. We're going to go over a couple of different things. Now, one thing to think about, right? So, technology dependence, right? These people, a lot of them are going to be dependent on this technology. Now, you're going to get called out to the scene. You're going to walk in, and maybe the family members are going to be telling you, "Hey, my or my family member is on this type of technology, and we need you guys to go ahead and treat them because of this medical emergency." You're like, "What am I going to do?" Right? I don't know what any of this stuff is. Well, there's typically three reasons why EMS gets called out to a patient with technology dependence. Well, number one is failed equipment. Either that technology that patient is on is failing. So it's important for you as an EMT to think, well, can I do or mimic whatever that technology does? Number two is a change in the patient's clinical condition, right? They're on that medical technology, it's been working for them, but something changed about them. All right, maybe they're on a ventilator, but they developed maybe pneumonia or something, or maybe they got a pneumothorax while they were on a ventilator, and so their condition is changing. Another one is maybe the patient's experiencing some other emergency. Right? Maybe a patient has some sort of technology dependence, like a vascular access device or maybe urinary catheter, but breaks their leg or something else. And so you're getting called out, but now you have to deal with this technology dependence as well. Those are the three typical or common reasons where we run into technology in the field. You guys, you're not expected to know everything about every single device. It's your job just to have a basic understanding. And remember, can I mimic what this technology does? If you're not sure, talk to the family members, talk to the patient if you're able to, because they've typically been trained by the doctors or by their primary care physician how to deal with this technology in their home. You can look over these questions. These are good questions and special questions to add to your assessments if you're ever dealing with technology. Remember, our job with these patients is to manage airway breathing circulation, maintain good oxygenation up to 94% via our SpO2, and get them to the hospital. The doctors hopefully can be able to take care or take over the technology if needed. Go ahead and take your time to review this case study. So as you can see, you responded to a 23-year-old who's ventilator dependent, but can speak by plugging their tracheostomy tube. Patient's skin is hot, and the EMTs begin their assessment, and the high pressure alarm goes off on the ventilator. Right? What do we do? How do we manage this? Right? Well, as EMTs, you guys are going to need to troubleshoot this situation. Go ahead, pause the video, and ask the following questions, and we'll resume when you're finished. Hopefully, you've had some time to answer the following case study questions. We're going to move on. Our first medical technology that we're going to talk about is oxygen, right? You're like, well, that one's not very hard. I've seen that or heard of that. Well, medical oxygen is oxygen that's used in home, right? Or people who have home oxygen. Maybe you've seen patients who are either driving their car or at the store and they're on oxygen cylinders. Well, that can be common for some people, right? Maybe they've got a concentrator or cylinder at home, right? So just be aware, is this patient on home oxygen? Use the same safety precautions that you would for the oxygen on your ambulance. Don't really deal with problems with oxygen systems too often, but sometimes the tank empties, or maybe the unit became unplugged, or they don't have good tubing, or maybe their humidifier became dirty or got plugged up. Right? Can we fix that? Absolutely. That's easy stuff that we all know how to change and how to fix. So if they've called you out and you don't know how to, or they don't know how to manage it, please help them with their oxygen system. Patient might also have an apnea monitor, helps patient monitor their breathing, and emits a warning signal if they ever stopped breathing. These are more common with definitely younger patients, newborns, and some babies to make sure that they continue breathing. As best as possible, you guys, if the patient is apneic, start breathing for the patient and start medical interventions, managing their ABCs, and figure out how long has this been going on for. Another common thing that you might see at home is pulse oximetry. I know you guys are familiar with pulse oximetry. So treat the patient as appropriately. Make sure that their equipment is working. And if you need to, switch them over to your equipment. A tracheostomy tube is another medical technological device that you might see in the field. Tracheostomy tube is a surgical opening inside the trachea to provide alternative route for airflow. Sometimes this will bypass the nose and the mouth. Sometimes these are only temporary, sometimes they are permanent. The permanent opening that's left without the tracheostomy tube is referred to as a stoma. The tracheostomy tube is placed into the tracheostomy to help keep it in the patient. Some patients with tracheostomies may not be able to speak. Some might be able to speak. Most common emergencies that we see with tracheostomy tubes is typically an obstruction of the tube, maybe mucus or pus gets in there and obstructs it, or sometimes the tube gets dislodged and they have a hard time breathing. You can suction a tracheostomy tube if necessary. You can see a couple of the different devices that they have here. When we're suctioning a tracheostomy tube, measure the depth of the suction catheter. You should always be using a French or soft tip catheter. Measuring can be difficult, so the patient should have what's called a tracheostomy tube obturator. This is a device that helps place the tracheostomy tube inside the patient. Measure the tube, or measure your suction catheter to this obturator, and then insert slowly. As you withdraw the suction, that's when you're going to apply your suction, and try and twist it between your fingers to help loosen up any of those big secretions. It's always recommended to rinse the catheter in between attempts. It's best to rinse it with something that's sterile. Another thing that we can see is CPAP or BiPAP. Now CPAP, if you remember, stands for continuous positive airway pressure, where BiPAP stands for bilevel positive airway pressure. This helps to provide some force behind the air that a patient is receiving. Some of these patients use these while they sleep. Some of these patients have to use them more oftenly if they have problems, maybe with their lungs. If you have CPAP, you can switch a patient over to your CPAP or get them on a non-rebreather or do a BVM. That might help give the same effect as a CPAP. Remember, you can always BVM a patient who is spontaneously breathing on their own. More advanced in CPAP is home mechanical ventilators. Now, a ventilator is a very advanced device that we might not have the ability or the understanding to use. And our job is not to change any settings on the ventilator. Patients need ventilators maybe because of different problems they've had, traumatic accidents, or even medical emergencies. And they can have home units versus units they have in the hospital, even some units that are carried on ambulances in other parts of the country. Remember, you guys, your job is not to change any of the settings. A lot of them have settings for the rate, the tidal volume, the amount of oxygen provided, even what system or what setting they're using. They have multiple different settings that some ventilators will be able to achieve. The tubing that attaches from the ventilator to the patient, typically the tracheostomy tube in this situation, is called a ventilator circuit. Make sure that's clear, make sure it's working and it doesn't have any holes in it. With our mechanical ventilators, we have a few different types of alarms that can help us figure out what's going on. As we remember with our scenario, we had a high pressure alarm that was being activated. High pressure alarms are due to a couple different factors. Typically, secretions inside the tracheostomy tube. Therefore, as the ventilator puts pressure down the tracheostomy tube, it's noticing that it's having a smaller pathway that is meeting more pressure as it's trying to put the air into the patient's lungs. That could be due to the secretions. So if necessary, take your patient off the ventilator, place them on a BVM, and suction your patient's tracheostomy tube. They can also have a kink in the ventilator circuit, causing that high pressure alarm to be going off. Straighten out the circuit, make sure it's all intact. And maybe if the tracheostomy tube has been dislodged, that is another reason for having a high pressure alarm. Don't forget to assess your patient with high pressure alarms, as sometimes the cause can be due to maybe pneumonia or even a pneumothorax. A low pressure alarm is when the ventilator notices that it has to push pressure down into the patient and it's too easy all of a sudden. It's not meeting enough pressure. This typically is some sort of leak or disconnection in the circuit. Assess the patient and figure out what's going on. The last two alarms are an apnea alarm. If the patient stops breathing, the ventilator is going to recognize it. If you notice this, remove the ventilator and start breathing for the patient. Troubleshoot the patient and then the ventilator. If the patient's not breathing on their own, they should be transported to the hospital via lights and sirens. And then lastly, the low FiO2. Remember, FiO2 stands for fraction of inspired oxygen. This typically alarm will be activated when there is no more oxygen or the oxygen source has been depleted. So go ahead and switch out the O2 tanks for the device. Best thing possible, assess the patient first and the ventilator. Remember, do a full physical exam. Listen for lung sounds. Is there something I can do to mimic what that device was already doing previously? If you need to, suction. Remember, if our patient has a tracheostomy tube, our BVM will attach directly to the tracheostomy tube. However, if they have a stoma, we should attach an infant BVM mask and place it over the opening to the patient and ventilate with the infant mask in place on either an adult or child BVM. Moving on to other technological devices. We're going to start with what we call VADs, or vascular access devices. Some patients who maybe spend a long time in the hospital or have to go to the hospital very often, well, they typically have to get poked by a needle over and over and over, and so they need vascular access or IVs all the time. Well, a vascular access device is a permanent IV, if you will. Right? They can be placed in a variety of locations all over the patient, and so we should assess them. We have a couple different types. We have what's called central lines or central intravenous catheters. We'll also have implanted ports. Here's a picture of a few of them. As you notice, on your patient's right arm, right about their elbow area, we have what's called a PICC line, or a peripherally inserted central catheter. Up at the top left anterior part of their chest, you see a little circle. That's called a portacath or a Mediport system. You also have more of a central cath, like the Broviac catheter, and then a femoral catheter as well. These are a couple of the common sites that you can find one of these vascular access devices. Typical problems with vascular access devices are, number one, is they can be obstructed by a blood clot. Some of these patients may be taking anticoagulants, so assess your patients and look at their medications. Sometimes air gets trapped inside the VAD device. In that situation, an air embolism can occur, resulting in potentially a stroke or even a pulmonary embolism. It's really important that you assess the site. A lot of the times, they become infected. These patients can quickly and easily develop sepsis because of where the infection is located. Notice if there's any redness, any swelling, any pussing, or the presence of any pus, and if it's hot to the touch. These will indicate that there's an infection inside in the vascular access site. Another device is called a vagus nerve stimulator. The vagus nerve is one of your peripheral nerves or cranial nerves that comes off of your brain. Well, this device helps stimulate your vagus nerve. Typically, these will help and keep patients from having seizures. It stimulates the device, preventing that patient or preventing the seizure from spreading. Other devices are associated with renal failure and dialysis. There's two types of renal failure. If you remember from chapter 23, there's acute renal failure and chronic renal failure. The difference is acute renal failure is reversible, where chronic renal failure is not. If their chronic renal failure has reached the worst stage, which is end stage, those kidneys don't work anymore. And now they need a treatment called dialysis. Dialysis is a process that removes the buildup of toxins from the kidneys, which they can no longer filter on their own. There's two types of dialysis. There's hemodialysis as well as peritoneal dialysis. Hemodialysis is typically done in outpatient clinics. Sometimes it's done 3 to 4 times a week for sometimes 4, 5, or 6 hours at a time. They typically require some sort of shunt or graft or access to remove the patient's blood to filter it. Peritoneal dialysis is done at home typically and can be performed overnight. A little bit less effective than hemodialysis. These patients will have a port that enters into their abdominal cavity where they will inject fluid to help them remove waste. Some accommodations for these patients. If the patient's getting dialysis treatment and is still attached to the machine, don't remove them prematurely. Have the dialysis staff take care of that. These patients can have severe bleeding and major problems. And typically with the dialysis clinic, there's a doctor on site. Patients with peritoneal dialysis quite commonly will develop peritonitis or even inflammation at the insertion site of their port. Sometimes that catheter becomes dislodged as well. All of these situations should result in a patient being transported to the emergency room so a doctor can fix the problem. Feeding tubes, and I'm sure you guys are familiar with, are there to provide nutrition to the patients when they can't chew or swallow. There's different types of tubes. There's nasogastric tubes, orogastric tubes, gastric tubes, and jejunal tubes. Nasogastric tubes are also called NG tubes, and they're inserted through the nose into the stomach. Orogastric tubes, or OG tubes, are inserted through the mouth into the stomach. And gastric tubes are called G tubes, and jejunal tubes are called J tubes, which are inserted into the beginning part, or the part of your small intestine. Here's an example of a feeding tube. Obviously, a feeding tube can become infected. So assess the site for any redness, swelling, any pus, or if it's hot to the touch. Ostomy bags is a surgical opening through the abdominal wall, typically with the large intestine or the colon, where it can divert fecal matter outside the body and into the ostomy bag. They can be placed in different parts over the patient's abdomen. It's important that you assess the patient's abdomen looking for these different devices. Patients can also have different urinary tract devices. They can have external catheters, suprapubic catheters, or Foley catheters, which is probably the most common, and it gets inserted up through the urethra. Here's an example of an external catheter and a Foley catheter. When we notice that our patient has a Foley catheter, we should always identify this before or prior to moving the patient. We never want to empty the bag on ourselves. We should always ask the nurse and talk to the nurse before doing it, as a lot of times those nurses need to document the patient's urine output. You can use the bag as an assessment tool. Look at the patient's urine. Is it dark in color? Is it cloudy? Is it red? All these things might exhibit different renal problems or different urinary tract problems. Maybe it'll have a bad smell to it as well, so make sure you use the bag to assess your patient. Always try to keep the bag lower than the bladder to create any or to stop any backflowing from the device. If any of the devices are dislodged, don't attempt to replace it. Take them to the hospital so the doctor can handle the displacement of the device. If you need to, if the bags are full, whether that's an ostomy bag or a catheter bag, try to handle it prior to transport. It's important that you refer to the nurse or the family members for their help. Don't change an ostomy bag or drain a catheter on your own without being trained or having some knowledge on how to do so. The next device we're going to talk about is an intraventricular shunt. Intraventricular shunts are used for people when they have excess amount of fluids on their brain, typically for a condition called hydrocephalus. This is a condition where they have an overproduction of cerebrospinal fluid, or CSF, causing increased intracranial pressure. The shunt will drain the fluid from the head, either back into the spinal cord or in the circulatory system, so it gets removed from the intracranial cavity. This is very common for an intraventricular shunt. A couple things can be a problem here. Number one is infection. So assess the site for any redness, any swelling, any pus, or if it's hot to the touch. Another big problem is a shunt occlusion, or bleeding inside the brain, or an infection inside the brain. A lot of these will present with intracranial pressure or increasing intracranial pressure. An infection inside the head or inside of the meninges can result in malaise or a weakness or not feeling well, fever, and headache. Typically, if a patient's shunt is occluded, they'll exhibit signs of increased intracranial pressure, which are listed below. Please take a time to write those down. These are similar to the ones that we talked about with trauma. Remember to manage patients' airway, breathing, and circulation. Manage their pulse oximetry. Oxygenate them to 94%. Get them to the hospital as soon as possible. Our last group of patients are terminally ill patients. Sometimes we call these patients hospice patients, and they are receiving what we call palliative care. Palliative care is the care that they need to make sure that they are comfortable as their time comes to pass. Typically, the life expectancy of a terminally ill patient is generally 6 months or less. Remember, we're trying to make the patient comfortable in these situations. A lot of different diseases that can result in terminally ill patients. Assess the patient. Talk to them. Talk to family members. Why is the patient on hospice, or why has the patient been diagnosed as terminally ill? What are the treatments? What is the care typically for these patients? A lot of these patients will have hospice providers where they'll have hospice nurses who will actually show up on scene and treat these patients. Sometimes these patients shouldn't be transported to the hospital. You should talk to the family, talk to the hospice provider, and figure out what's best for your patient. And as necessary, talk to your medical director. Sometimes it's difficult treating patients based off of patient's will and the family's will. What needs to be done? Some of these patients will have DNRs or pulse documents. So as best as you can, follow the patient's wishes and the family's wishes. If necessary, provide emotional support to the patient or the family members. Go ahead and review the case study conclusion, pausing if you need to, as we go ahead and finish up Chapter 40. And that's it for Chapter 40, guys. Great job. Make sure you get in there and review your book. And keep up the good work. Thank you guys very much.